Hi, it's Dr. Centeno, and today we're going to talk about an important topic. I had done a Facebook Live on this, but I think we were having some bandwidth issues, so I wanted to redo this to make sure everyone heard this important message. So today we're going to talk about injecting high upper cervical facet joints, going to talk about a physician's assistant who tried to do that. I'm not going to get into names of clinics or names of providers, but just to try to use some stills from this video I was sent to educate you about how injecting the upper neck facet joints, especially in CCI patients, for example, is something that needs to be done very carefully, and so that you can identify when you're with a provider who understands how to do that versus who may not understand how to do that safely. So again, injecting these hypercervical facet joints 0-1, 1-2 is something that requires a lot of experience and training as well as specialized equipment. And the facet joints are little joints in your neck about the size of a finger joint. And there's two at each level, one on the left, one on the right. And we're talking today about 0-1 and 1-2, the hypercervical facet joints. Now, a colleague sent me this video. This was a physician's assistant in a prolotherapy office who seemed to be injecting prolotherapy solution into the C1-C2 facet joint, or at least that was the claim. And as you'll see, I don't think she ever got there, but it's a good way to learn about how these procedures can be done safely versus not. So again, we're using this video, or at least stills from it, for educational purposes. And I'm taking stills from it just to protect the identity of the provider. So the first thing we see on this video is this is a really big needle. This person here is female, not that big, meaning we're not seeing an overly obese person. So the question is, why is this sort of needle being used? Now, it's not only the width of that needle, but the length, and that only becomes important because of how it's inserted. There are ways to insert a big needle like this to mitigate the risk, but in fact, this needle is going to be inserted in such a way as to maximize the risk. So notice that when you're inserting a needle underneath an ultrasound probe, and the goal is to see the needle as it goes to a certain part of the body. There are two ways to do it. You've got short axis, and short axis is when you come on the side of the probe. Now, the problem with short axis is all you really see is the needle tip on the screen, so it tends to be a little higher risk. Now, there are times when it's not a big deal because you're in a low risk area, but here we're in a very high risk area. So short axis here would be the highest risk procedure you could do. In this case, we're going to be looking at long axis, or at least that's the recommended way if you were in a high risk area. And that's where you can see the whole needle and see exactly where it's going to go. So if you were going to do an ultrasound guided injection in a high risk area, long axis would be the way to go. Short axis would be riskier. And with short axis, we see that the probe is designed in such a way, and all the probes are like this, that if you follow parallel along this line at the side of the probe, the needle will end up underneath your ultrasound beam so that you can see it. Now again, all you're going to see is a little tiny dot if you're on short axis, and that's what makes it a bit riskier to use. Now here, from someone who's used this exact ultrasound probe many times, and looking at the angle here of the probe versus the angle of the needle in the syringe, and the depth that's been deployed in this person, what's happening here is something that happens in inexperienced providers. And that is what the PA is really seeing is the needle here at this level. And she's likely, in my opinion, lost track of where the actual needle tip is in the body way down here. So the dot that she's seeing is merely where the needle crosses this ultrasound probe, and not where the needle tip is located. And that's a rookie mistake. I teach fellows, so I see fellows make it all the time. We correct it, and it comes from using too long a needle and not coming parallel to the side of the ultrasound probe. But the bigger issue is that, in my opinion, she's lost track of where the needle tip is in a very high-risk area to inject. So what happens if you lose track of the needle tip in this location? Well, you could be injecting into the vertebral artery. That's going to cause a posterior circulation stroke. That's a bad day for everybody. You could be injecting into the spinal canal, which would cause a high spinal, and the person stops breathing, and you have to be able to resuscitate them. So not a good thing in this area. So here what I'm showing you is this same injection that we just saw before. And looking at the screen, what's happening is the anatomy looks like this. So this box that I've drawn here, this rectangle, yellow rectangle, is what this person is seeing on the screen. And she's trying to hit this little spot right here at the C1-C2 facet. But because she's coming in at an angle, there's a danger zone off to the left, which is the spinal canal, and a danger zone off to the right, which is the vertebral artery. So because of the way this injection is being done, this has maximized the size of the danger zones and minimized the size of the target. You want to do the opposite. You want to maximize the size of the target and minimize the size of the danger zones. And then on top of that, we have a needle that's too long for this type of short axis injection. And we also are in a situation where, in my opinion, the tip of the needle is no longer being seen by the ultrasound screen. So again, what I would say a high-risk approach, now a high-risk injection because of lack of knowledge of how to do this. So are there ways that we can dramatically improve patient safety here? And absolutely, lots of different ways. One is for this particular injection, as I'll show you, C-arm fluoroscopy is the way to go. It's just going to show you a lot more, and ultrasound is going to be higher risk. Now, again, if you're going to use ultrasound, you'd want to do it on long axis, but because it's being done on short axis, that's increasing the patient's risk. And using fluoroscopy, which is the image over here, you want to go into this sagittal plane where you're going straight down, because now you've increased the size of the target, the C1-C2 facet joint, and you've moved the no-go or danger zones off to the side. And as long as you stay aligned with this joint target, which you can see very easily under X-ray guidance, you're not going to slip more medial or you're not going to slip more lateral. Hence, much, much safer here. And I don't have to have the ultrasound beam in the right angle. I don't have to worry about whether or not I'm really imaging the needle tip. I can see the needle the whole way as it goes in and know, as long as I follow other benchmarks, that I'm not anywhere near these danger zones. Again, much, much more difficult to do on a short axis injection and the angle that that provider was using. Using this sagittal angle minimizes these risks. And obviously we talked about this. You want to use long axis if you were going to use ultrasound and not short axis, because if you miss the target, you're more likely to be safe here. If you miss the target over here using short axis, you're a very aggressive approach that's going right towards structures that are really important. In addition, you want to use digital subtraction angiography, or DSA. That means that it's a special software package usually used in interventional cardiology, but present on all of our machines, where you can run that DSA loop and see if you're in that vertebral artery, because you get rid of all the background. So all you see is the artery if you're in the artery. Now, that's okay. It's okay to inject into the artery something as innocuous as a type of radiographic contrast that's used to inject arteries. That's not a problem. But if you were inadvertently in the artery on the ultrasound, it would be much, much harder to see, whereas digital subtraction angiography under fluoroscopy makes it much, much easier to see. And you want an arthrogram, which you can again see very easily on X-ray guidance. You can see the contrast is going in the specific places where you'd expect it to go if this stuff was going in the joint. You can't see that under ultrasound in this joint, C1-C2. Other joints you can. This one, very difficult to see if that stuff you're injecting is going into that joint under ultrasound. Here you're injecting contrast before you inject anything else and then observing it going into the joint. And you want to inject again, and I've talked about this, something innocuous, which is going to be that contrast designed to be in joints or arteries before injecting the active agent. And that's just common sense, right? In that ultrasound, there is no way to inject contrast under ultrasound, so you're just injecting the active agent. So if you put it in the wrong spot, bad day for everybody. If for some reason it's in the wrong spot with using radiographic contrast, not a problem. So that's the reason, again, here to use C-arm fluoroscopy for this particular injection. And then finally, it makes no sense to use a PA to do this procedure when that PA has half of the experience of a physician subspecialist. So again, that just makes no common sense. You'd want to use a physician subspecialist to do this procedure because they've got a lot more training and experience. So in conclusion, these procedures can be done safely, but you've got to use the right equipment. You've got to use a physician subspecialist, not a mid-level or not a doctor. And obviously there's lots of ways to keep patients safe, but as you've seen, it involves using different techniques, different imaging capabilities, contrast before injection, etc. And again, as a patient, getting educated in all this will really help you stay safe. So I hope that you learned something by watching this. Thanks so much for watching, and have a great day.